House Bill 2323. This bill on your marked calendar says that it's going to be rolled 1 week by the sponsor. However, we do have people here today that would like to testify on this bill who have traveled in the snow. And so I've talked to Dr. Kumar, and we're going to ask them to testify. So even though it's different than your marked calendar, Dr. Kumar, we're going to hear from these people today. House Bill 2323, you are recognized.
Thank you, Mr. Chairman. I certainly appreciate your efforts to accommodate our requests. This is a bill that allows people in the low-income category who do not qualify for TennCare coverage to be able to have a private arrangement or a personal arrangement with a physician. It is strictly between a doctor and a patient, where the patient will pay them a small sum, usually in the $50 to $60 a month range, for which they will receive primary care services. But there are physicians with such a kind heart who are doing this in practice at this time in our state today, but they are few, and one of them is here and will testify. Our effort with this bill is to avoid such a personal arrangement between a doctor and a patient from being regulated under insurance guidelines or rules. And I think it empowers people. It allows them to get care that they cannot get because of the limited public funds available.
Thank you, Dr. Kumar, for that explanation. Without objection, we're going to go out of session to hear from the doctor. If you'd come forward and state your name for the record. Without objection, we're going out of session.
Good afternoon. Thank you for allowing us to talk today because we came in the snow. I'm Kim Howerton. I'm a board-certified family physician from Jackson, Tennessee, and I am a direct primary care physician. I provide direct primary care not only for my patients that do not have access to care, but I provide it for all people that have insurance. Most of them have high deductible plans, so this is an economical way for them to obtain care. If you think about direct primary care, it's old-fashioned medicine. It's being able to call your doctor on Saturday afternoon because your child fell and cut their head and the doctor meets you at the office. It's having my personal cell phone so they can call me anytime they need me. They do not have to go to an urgent care facility. It reduces costs by having that access. Also, most importantly, and what makes my heart happy, it allows me to sit with my patient. We have 30-minute appointments, and he or she and I talk about their health. We talk about the ways to promote their health. If we need to, we do diet plans. We actually meet at the park and exercise. But it allows me to take time to promote health and prevent disease. It is liberating in a lot of ways because it is just that patient and myself in the exam room, and we can take care of them and identify their needs and their wants and move forward with them. This bill is before you because we want to continue to follow the rules. We want this to be a type of practice that is not regulated as insurance because it isn't insurance. It is truly just a private relationship between the patient and myself. But it's old-fashioned medicine with a modern touch. I'd entertain any questions if anybody has
any questions while we're out of session. Yes, sir. Chairman Faison, you're recommended.
Thank you, Mr. Chairman. Thank you so much for being here. As I spoke with Representative Kumar this morning, I can't imagine why anybody would be against. This seems like just really good common sense things that any state should do. Could you briefly tell me, are there people who would oppose this? And if they would oppose it, what would be their reason to oppose this?
We have not found anyone that opposes this. Even the insurance companies find this favorable. For them, it means that they're not dealing with paperwork for those claims that are not they're not met because they're not at their deductible yet. So even the insurance companies are going to save money with this. I haven't found anyone that opposes this.
Yes. Representative Armstrong, you're recommended.
Thank you, Mr. Chairman. Have you ever heard of healthcare ministries?
Yes, sir.
They provide similar as what you're talking about, I didn't know if you were part of a healthcare ministry that you're looking at
You're talking
providing.
the one that actually has the silver, the platinum, the silver, and the
Yeah,
gold plan.
it's
and
about
it's that they
three
pool
that
their
are
money.
nationally recognized that, you know.
I do provide that care, and I joined that organization prior to starting my DPC because I wanted to provide access for people that didn't have health insurance.
Right.
Now that I have this plan, I haven't had anyone present with that need yet.
You know, as I heard you describing yours, and I know that there are three. It's a Samaritan and one in Florida, and then one out of Ohio, Christian Healthcare Ministries, that are going across the country. But one thing that yours does not provide, the way that this bill is, it wouldn't give that person an exemption to the healthcare, the Federal Healthcare Act. They would still be responsible to the IRS to provide the health care. And I was saying that what you're doing, if you move one step further, the one exemption to the Affordable Care Act is the healthcare ministries. And they would give additional protection. And what you're doing, providing this care, might be the next step that you need to do to make sure if someone is paying for their health care, if they're paying you a certain amount each month, then they ought to get credit as far as requirement when it comes to their federal, because this year they're going to get hit with 400 and it goes up. So
And on the federal level, there is some work concerning that because people should be able to use their health savings accounts to pay for this. But that's more on a federal level for us.
but to my understanding, the way that you're doing, and I guess I should ask the sponsor this, but the way you're doing it would not exempt someone from the requirement of the Affordable Care Act as far as the IRS. But the Healthcare Shared Ministries would add that exemption for you if you include them in your scenario.
And actually, right now, as things are in Tennessee, I encourage my patients to have health insurance because insurance is supposed to be for those catastrophic, unpredicted events. I can't do an appendectomy in my office. They need to have coverage for that. They need to have that safety net so they're not going to exhaust all of their resources. So right now, I still encourage all of my patients to have health insurance, just high deductible plans if they can afford them.
Thank you. Dr. Kumar?
Thank you. I would like to point out what I realized today, that this is concierge medicine at the humane level. Those of us those people who cannot afford that. And while talking to Dr. Harberton, one interesting concept came to mind, and that's a new one called Robin Hood medicine. Would you kindly explain it to them?
In a Robin Hood practice, a physician can take a monthly fee, and it would be a little bit more than what would be expected, but that participant knows that they are financing the care of someone who could not afford that. And there are some Robin Hood practices, but with direct primary care, it's for everyone. It's for that person that can't afford health insurance. It's for that person that is forced into a high deductible plan. I have quite a few people that have low deductible plans but want the dedicated time with me. They want me to spend more than 7 minutes with them. They want that 30-minute appointment. So truly, direct primary care goes across all economic spectrums.
Chairman Sexton, you're recognized.
Thank you, Mr. Chairman. Can you kind of explain this to me? So the patient pays a monthly fee or something to the provider, right?
Exactly, yes.
And that guarantees them some type of service.
It gives them a certain number of visits per year. I'll just use my practice as an example. For me, an adult greater than 30, it's $49 a month. That ensures their visits with me for the year. 3 sets of labs, comprehensive cholesterol, diabetes testing. And it also means that they can contact me 24/7. It's my direct cell phone number. And it allows them to communicate with me through secure messaging, things of that nature.
So if you were looking at this, would it be considered more of a wellness type of plan? No. It's
It is broad spectrum. My hope is that it's wellness based, and eventually we get to a place where we've spent enough time on the front end to prevent disease. Right now, where we are, there is still a lot of chronic disease management. There's also acute care. If someone has a sinus infection, if they cut their hand, they can meet me at the office and I'll sew them up right then.
So if you have a patient who has that high deductible plan and they sign up for your $49 a month plan, right? And they come in your office and it's something more than a wellness visit, and it's theoretically you have to run different lab tests, there's procedures you have to be done, so forth, so on, and it's like a $500 normal bill, right? So they paid nothing out of pocket,
Nothing.
and then you don't bill the insurance either.
No, I do not bill insurance.
Could they send the claim in to try to claim that as a deductible in insurance, or does insurance know that they can't claim that as a deductible if they send it in themselves?
Most of my patients do not submit it to their insurance because they have such a high deductible. Theoretically, they could take the form, they could ask me for a form or a receipt for that monthly bill and turn that into their insurance.
Right, because I'm just sitting here thinking that if the patient is paying $49 a month and there is a circumstance that you would think that they would want to turn things in on their deductible at some point in time, but then I don't know if that means that you're held liable at that point to collect that money or not. So if they turn into the insurance and they're like, you that goes towards your deductible, but they really don't pay it, does it really go towards their deductible or not? Because there's no money exchanging hands.
Like I said, most of my patients don't ask for that at all because it's such an affordable amount. And most people are not going to meet their deductible, even if it's a $2,000 deductible. Most of them are not going to meet it without a catastrophic event.
Right, and that's what I'm trying to bar from. But, I know we're rolling this bill a week, so, I wouldn't mind maybe having more information on how the insurance side would work, if it works its way through the process, and what it does look like once it leaves the office.
Thank you, Chairman. Any other questions while we're out of session? Seeing none, we're going to go back in session. Thank you for your testimony here today. Dr. Kumar, based on our previous discussion, we're going to roll item number 23, House Bill 2323, 1 week. If any other members have any other questions, more than happy to call Dr. Kumar.
Thank you.
Thank you.